Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I'm thankful, Ji. So I don't want to go in details about COVID. We know much about COVID now. So COVID is a very complex disease. It's causing a lot of confusion in the health society. What to do? One time they say the hydroxychloroquine is working very efficacious. Other day say, oh, sorry, it's not working. So really, it's a lot of mess and a lot of confusion is going on across the world. So in this era, the doctors and the physicians to be smart enough what to do, what not to do. Because as I told yesterday, we cannot give all the medications under trial. Maybe 20 drugs are under trial. Somebody knows some medication. Some company people say start in this medication. No, please. So try to manage the patient with a logistic approach. See what can we do best for the patient. Do more harm and less. Sorry. Do more good and less harm to the patient. This should be your attitude. So pathogenesis is a complex disease, complex pathogenesis, complex manifestation, and complexity of treatment. So I'll discuss about this contents, inshallah. So I take my reference from the ICMR guidelines, WHO guidelines, DMJ, and others. So basically, as we know, already we have 4 pandemics till now. And as we know, there are 7 to 9 coronavirus exist in nature. And as per history, coronavirus exists in nature from 9th century BC. So this is not something new one. So already in the nature. So as the time permits, the virus gets opportunity to have a pandemic. So already we have 4 pandemics. So maybe we have more in future, we don't know. So as we know, the mode of transmission is mostly droplets. That's the importance of social distance. Because once you have distance of at least more than 1.5 meters, the droplet secretions come from one patient, will not follow others. The most important aspect of prevention is distancing. Then hand washing, then comes the mask. So because the transmission is mostly droplets, try to focus on hand hygiene and as well as social distancing. Second thought is still not clear. Could be airborne disease. It may stay in air for some days, some hours. Exactly, we don't know. And as Dr. Fauzi talk about this fecal transmission, maybe 2% patient may have diarrhea. They may have fecal oral transmission. So signs of symptoms, as I told you, they have complex manifestation. But WHO and CDC has given at least basic guidelines how to approach. Any patient of fever, whatever it may be, maybe something else, but any patient of fever, please don't forget about corona because the pandemic. Maybe patient has a meningitis, but suspicion of corona should be there. Once the patient has got fever, suspicion of fever should be there, should be isolated in a single room in the hospital. So fever has been reported in almost 88%. Then next comes the dry cough and fatigue, and we can have multiple symptoms. Patient can have diarrhea, nausea, vomiting. And other thing, most important thing, I come across basically, many patients they say, I have some sore throat and loss of taste. Oh, just a warning sign for me. Oh, could be corona. See, they don't have much fever. They have mild fever only, but basically they have sore throat with loss of taste. So could be corona. So patients of corona have got multiple manifestations, but by today, CDC guidelines say more common manifestation of fever, cough, myalgia. So let's have this the definition of COVID, because the definition will guide us from where to go. Actually, any patient of fever with acute respiratory illness, either upper respiratory or lower respiratory infection, then we should suspect first corona. So as per definition, you can see patient with acute respiratory illness should be considered as a corona. Second thing is patient with lower respiratory, patient with lower respiratory, upper respiratory tract infection with other symptoms is contact with COVID patients, then could be a part of definition. So any patient with acute respiratory illness, either upper respiratory tract illness or lower respiratory tract illness, suspicion of corona should be there. So again, this person who meets suspected case is a definition by COVID. A person who meets suspected case definition and confirmed with COVID is a case of COVID. So pathogenesis. Pathogenesis, as I told you, pathogenesis is complex. Basically, as Dr. Fauzi told us very nicely, it is this virus has the affinity for the receptors of AC inhibitors. AC inhibitors are present in many parts of the body, in the heart, in the lungs, in the kidneys, in the vessels. That's what this virus is a multiple organ, they can cause multiple organ failures. So basic pathogenesis is it attacks the AC inhibitors and affects the, say, can affect the cellular immunity as well as humoral immunity and hyperimmune response syndrome. You see next slide. So basically complex disease, complex pathogenesis. This slide is very important for a physician because we can decide at what level patient can be managed and what to be given. So as I said, first is the incubation period. As we know, the incubation period is from 2 to 14 days. The patient can have manifestation in 14 days anytime, but mostly they can have symptoms in 5 days. Okay. Then from 5 to 10 days, these symptoms could be mild. We have seen many patients just have sore throat, fever for 1-2 days and they improve. So this phase is just a mild case, an acute mild phase. From here, just what physician should be asking of the patient how many days they have first day symptom. So patient say, no, I have 10 days symptoms, then still I have fever, then physician should be on the toes. Oh, from 10 days he may go to the ICU, he can go to the ARDS, he may go to severe complication. So always take history from patient. How many days? So patients say I have persistent fever for more than 1 week. So near coming to 10 days, patient may go into severity. So this is very important factor. Take always history of the number of days of duration of illness. Second thing is from 10 days onwards, patient may go to the severe pneumonia, he may go to ARDS, he may go to hyperimmune response syndrome, he may go to cytokine storm. So always try to concentrate this part. How many days illness? Within 10 days, patient improving, it's well and good. After 10 days, patient is not improving, then should be caution of physician. Each patient should be hospitalized, at least do basic workup. So this slide also shows these are 3 stages of viral infection. First is viral response. Second is lung response, pulmonary response. Third is hyperinflammatory phase. So viral response usually in early phase they may have mild symptoms. Lung response, once they have lung response, they may have pneumonia. They have fever, cough, sputum, and short of breath. So this phase, again, it depends. Some patient may improve, some patient may deteriorate. Again, I told you, their 10th is very important. So from here, patient may go to hyperinflammatory response phase. This phase can cause cytokine storm. So this slide show again this as I told you, the complex pathogenesis. It can cause hypercoagulable state. It can cause endulopathy. It can cause microthrombus. Microthrombus ultimately patient will go to ARDS and multiple organ failure. So this slide till now we are talking about lungs. See about the heart. So Dr. Nurla will talk about these issues. So multiple levels, the heart is affected. So it can cause increased microinfarctions. The patient came with chest pain. So maybe a sore throat. So don't ignore this. Patient of MI patient with a sore throat could be corona. So please any patient of patient, please have suspicion of corona until unless proof otherwise. So patient can present heart failure, patient can present arrhythmias. So now let's go for the how to assess the severity of illness, because as I told you, mild to moderate patients are 80%. They can be managed at home. So again, physician should know which patient can be managed at home. And some patients are very crucial, borderline cases. They can be admitted, can be managed at home. Because the load on hospital is very huge, and because of the financial issues, patient can be managed at home, which are borderline cases. But you have to be cautious. Every 4 hourly, physician should be having contact with patients, what's going on. So this is good news, at least 80% patient can be managed at home. So now let's discuss about the severity, how to assess severity. Mild symptoms, as we know, patient can have some mild respiratory illness, maybe has sore throat, fever, cough, nasal congestion, without evidence of short of breath, dyspnea. This is mild. Moderate patients means patients will be with no signs of severe disease, but he has already involved the lung. So he has signs of pneumonia, fever, cough, patient may be breathless. But the saturation, you can see here, the saturation is still less than 94. So again, is the alarming one. This patient may go to severity. So any patient who has got fever, cough, dyspnea, try to monitor pulse oximeter to look for saturation. If saturation is going 94, then it's a moderately patient now. Suddenly, this patient may go to severity in time. So again, also in childhood, children, we also check the saturation. Less than 94 is a warning sign. I check the respiratory rate. More than 24, usually more than 24 rate in the adults, and it can be more than 40 in the childs. So patient may have mild tachypnea. Now comes the severe case, severe pneumonia. So this is a case physician should be alert and try to decide that the patient needs admission. So now patient has got tachypnea. The respiratory rate is more than 30, and saturation is 90. Any patient who has got saturation less than 91 is respiratory failure by definition. Respiratory failure means PO2 is less than 60, saturation less than 94, and PF ratio less than 300. Next slide, I'll show what is PF ratio. So as a physician, you should know what is PF ratio because everybody is talking about PF ratio. So any patient who has got saturation less than 91 is acute respiratory failure. So then this patient need to admit in the hospital basically. Suppose for any reason patient cannot manage, then we can provide oxygen at home and monitor every 4 hourly. From here, from severe respiratory illness, patient may go to SIRS and may go to sepsis. So Dr. Parvez, inshallah, will talk about sepsis tomorrow. So acute respiratory distress syndrome is just a definition you should know. Because what is ARDS? ARDS means at least should have 4 things. Patient has severe breathlessness, severe short of breath. Then patient will be tachypnic. An X-ray will show diffuse infiltrations and severe hypoxia. Okay, and then we have ratio of PF ratio. If less than 300, it is ARDS. Otherwise, other definition also you should know pulmonary capillary wedge pressure. If pulmonary capillary wedge pressure less than 50, again is ARDS because this is basically pulmonary edema. So you should know is the cardiac or lung as from the ARDS. So pulmonary capillary wedge pressure will decide. So the students of going for exam, they should know this. So ARDS is tachypnea, severe tachypnea, severe hypoxemia, bilateral infiltration in the lung, then PF ratio less than 300, and this pulmonary capillary wedge pressure less than 15. So as I told you, the patient may have mild ARDS ratio less than 300, moderate ARDS ratio less than 200, and severe ARDS ratio less than 100. So because of time, I may skip some slides. Okay, so this diagram is very important. Again, clinician should know 80% patients are mild cases. See, only 15 patients are severe cases which require hospitalization. So not to panic. So this message should be given public. Any patient have fever, they should not rush to the hospital. They can stay at home. Even they should not go to polyclinics. They just call the doctors, they call the NGOs, and it has a telemedicine conference with the doctors. Should be at home because this time the community, the virus can spread to other people. So any patient has illness, physician should give them advice not to come outside the home, stay at home. And 15% patients can need admission. Good news is that only 5% patients require ICU. So this slide regarding which of the patients are high risk patients. As we know, diabetic, hypertension, cardiovascular disease, lung disease, kidney disease, chronic kidney disease, and chronic liver disease. And this regarding CRP and all these, Dr. Zubair will talk about. So high CRP, high CPK, high ferritin, all these are risk factors. Okay, and hypoxia. One patient has got hypoxia less than saturation less than 93 is a high risk patient. Tachycardia is very important. Sometimes patients are having normal saturation but tachycardia, so should be a caution. And respiratory rate more than 30, and low blood pressure with altered sensorium. These are the high risk patients. They may go into severity. Okay, this chart I brought because somebody asking what is the normal saturation, what is the normal PO2. So any patient who has got, you can see from here, see this is a PO2 of 60. Then saturation is just above 80. So means PO2 of 60 is means saturation is below 90. So any patient of saturation 90 is PO2 can be taken as 60. Means it is respiratory failure. So this is a message. So we don't need to do ABG for all patients. So once the saturation less than 90, this is a respiratory failure. Okay. So now with many questions, patients are asking how to know this patient has this respiratory problem, respiratory illness. So we can do ask the patient to can do some bedside assessment. Ask the patient to breath holding. Okay. Take a deep breath and hold. If they can hold for more than 25 seconds, it's normal. If they hold from between 15 to 25, if they have limited activity, limited lung reserves. Less than 15 is very poor reserves. So this is a bedside test. You can ask the patient just to hold breath, hold, take deep breath and hold. If they cannot hold more than 25 seconds, this is warning sign. Okay. Other thing is ask the patient to count in single breath. Normally they should count less from 30 to 40 seconds counts. If they cannot count more than 30, it means patient has got respiratory illness. So I was talking about PF ratio. This junior doctor should know how to calculate the ratio. So PO2 is about 97 and FiO2 is 21. So normally if we are taking FiO2 is 21%. We know because oxygen is 21% in atmosphere. So 97 PO2 divided by 21 is 461. Okay. So you should divide PO2 by FiO2. FiO2 is 21. So the ratio is more than 400 is normal. One thing message I want to give you here, because some patients on oxygen, how can you know FiO2? It's just simple formula. Already, you know, FiO2 20 is atmospheric pressure. Then every liter of oxygen you have to add 4%. So patient taking 5 liters of oxygen. So 5 multiplied 4 is 20. 20 plus 20 is 40. So 5 liters of oxygen, patient taking 5 liters of oxygen, FiO2 will be 40. So just divide 97 by 40. So simple formula. So just remember, 1 liters will provide 4% of FiO2. Okay. So something, because media people are talking about silent hypoxia, happy hypoxia. You should know this. What is silent hypoxia and happy hypoxia? So basically, patient comes to the hospital with some other illness. They have fever, they may have diarrhea, they have nausea, some abdominal pain. But once you see the saturation is below 90, this is silent hypoxia. So why this? The mechanism is not clear, and it could be because of the disturbed what you call neuro response from we have this hypoxic drive from brain. So this may be because already corona affects multiple organs. So decreased hypoxic drive can cause silent hypoxia, and there is still not clear mechanism. But one of the possibilities is because of the poor respiratory drive. So silent hypoxia, some patient comes to hospital, less than saturation 90, but their clinical looks is not tachypneic. So this is silent hypoxia, and they can kill the patients. That's what patient should monitor oxygen saturation by pulse oximeter. Okay, so we discussed already ARDS. So as I told you, mild ARDS is between 200, ratio is between 200 to 300, and severe is less than 100. Okay. So now next 5 minutes, because this talk will be dealt by Dr. Yadullah tomorrow. He's a very good experienced teacher. But just touches some important points. So management by smart approach. The word is very important. Smart approach. So means one patient has got corona, even suspected corona or positive corona. We are not going to dump the medications. Please, I told you yesterday, polymedicines will harm the patient rather than being good to the patient, because there may be interactions with medication. We don't know. There may be some complications. So patient may die of complications. So please don't try all the medication what is available. So again, this lab part will be discussed by Dr. Zubair. You should do this basic workup. When to do? So for patient have fever for 2 days, I not do any workup. I just wait for 3-4 days. Still patient has got fever, then I'll start working from the day, look for CBC, look for the lymphopenia, then look for the CRP and the other markers. Dr. Zubair will talk about this issue. I'll keep this slide. So, how to manage pneumonia? So, I told you mild infection, patient can be given azithromycin. Azithromycin has been shown to be efficacious by many trials. So even our experience in Saudi Arabia, we have given to many patients, they are very happy. So we can try azithromycin 400 mg single dose for 5 days. Okay. And these other recommendation for ICMR is we can also use chloroquine. But now WHO has a second opinion about chloroquine. They want to remove the WHO chloroquine from the trial pool. Okay. So mild cases, just give symptomatic treatment, boost the immunity, and we can start azithromycin. Okay, so this is from the ICMR guidelines. They are starting hydroxychloroquine from the day first. So I told you it's a choice. So we can try with azithromycin. If not improving, then we can go for the hydroxychloroquine. In our opinion, what we are doing here. But this is a guideline from the ICMR. You can follow. It's up to you. Now regarding moderate pneumonia. Now this is a thing. I told you this is a borderline cases. This patient anytime can go to hospital. We need admission. So always try to target the saturation. Look for the pulse oximeter every 4 hours. So saturation target should be more than 92. Anything less than 91, I told you, is respiratory failure. So we have to be very cautious. And again, suppose patient has got respiratory failure, less than saturation 91. Giving oxygen and just keeping the patient at home is not also safe. Patient see the patient clinical condition, patient tachycardic, patient tachypneic. No, this patient to go to hospital. So oxygen is not the treatment of only to be kept given at home. Patients should be monitored closely. Anytime, especially old age patients, because tachypnea for a few hours, for a few days, ultimately they have fatigue. They may have respiratory arrest. So this is very caution. Any patient of saturation low should be monitored closely. After giving the oxygen, patient may improve, the saturation may improve. But still tachypnea is there. So if respiratory rate more than 30, I advise to go to hospital. Second thing, they are talking about this arrhythmia. Arrhythmia, I'll just show you pictures. Patients should be in prone position. Why? Because mostly lower lobes are the posteriorly. So once the patient lie down on posterior, prone position for some hours, so lower lobes will have good oxygenation. So this is the advantage of proning. Okay. Then, so patient is hypoxic, we can start dexamethasone and methylprednisolone. Again, don't start dexamethasone and methylprednisolone from first day. We are seeing patients coming with no hypoxia, no signs of pneumonia, they are starting dexa. Because this is viremia. We are treating viremia anytime because we need to have good immunity. The dexa and the steroids will decrease immunity. So please don't start steroids from the first day. The only indication is basically patients who have got hypoxia. Then regarding anticoagulation, again is important factor because you should look for D-dimer 0.5 to 1. It should give 40 mg of COD. Again, Dr. Zubair will discuss about the issue. So in general, patient with moderate anemia is borderline. Anytime he go to hospital, so monitor saturation, give oxygen, and clinically assess the patient tachypnea and tachycardia, blood pressure, fever. It's not responding, then he should go to hospital.
Sir, you have 5 minutes left.
Yeah, I'm finishing, Dr. So just a general guidelines from the updated. So steroids should be used only in severe patients or critical cases. Hydroxychloroquine can be used for mild to moderate cases without oxygen requirement. Then this Fabiflu can be used for all patients. Okay, again should be used a logistic approach. Patient for 2 days fever, I should not start. I just wait about at least for 3-4 days. Okay, triple therapy can be given only in severe cases due to non-ICU cases. Okay, so this is a severe hypoxemia. Again, this will tomorrow Dr. Yadullah will discuss, inshallah. This is a prone position. So patient should be at least for 30 minutes prone position, then right lateral, then left lateral, and then sitting position. Okay. So as I told you, indication of steroids, only patient has got hypoxia. Don't start steroid in the initial phases. It will harm the patient. Again, in ER also you should have a triage system because which patient need admission, which patient need ICU. So there should be a triage system. This is a chart for the triage system. So in conclusion, 80% are mild to moderate cases. Good news, patient we can manage at home. A smart approach is very important. I'm telling this word, smart approach. Don't give DEXA from first day. Don't start antiviral from first day. Wait and watch. Maybe the patient will improve 2 days. Why you want to give this antiviral and patient to have some other complications? So follow the guidelines. Guidelines will support you. Avoid polypharmacy to avoid drug interaction and complications. Thank you so much.
Thank you very much, Dr. Ubaid. Thanks for setting up the tone for the rest of the talk. Dr. Ubaid has elegantly highlighted the important point of being a medic. Do no harm. The first oath as a physician is to do no harm. That's what Dr. Ubaid is trying to get the message across to the rest of the panel attendees. I just want to make a small adjustment in the webinar today. I'm pleased to inform you that Dr. Razi Uddin Ahmed, the pulmonologist and intensivist from Houston, Texas, have joined us briefly for 5 to 10 minutes. He's leading the intensive care unit in Methodist Hospital in Houston. He's very much involved deeply in the management of COVID pandemic and intensive care. And I was speaking to him earlier today, and he's been sharing quite horrendous stories what's happening in America. If Dr. Ubaid is okay, can we get Dr. Razi speak for 5 to 10 minutes to share his experience? If that's okay.
Definitely, sure. We are pleased to see him in our podium.
Dr. Razi,
I welcome Razi again.
Most welcome. Assalamu alaikum. Welcome.
Wa alaikum salam. Thanks, Dr. Zubair, for delaying your presentation by 5 to 10 minutes.
It's all right.
Benefit from Dr. Razi's experience. Dr. Razi, it's over to you.
All right. Assalamu alaikum and good morning. Good morning for me, good evening for you all. It's so good to see you, Noor and Ubaid Bhai and Zubair Bhai after a long time. Thank you for involving me. So already you have seen the presentations. I am very sorry that I could not do it in a more proper way because I didn't have time. We are going through pretty bad surge here. We started with 20 and 40 patients in early March. I myself got coronavirus infection, suffered quite a bit. After 2 weeks, I got back. Alhamdulillah, I'm doing well. Back in my hospital, doing what I am supposed to do. And I commend you all that you put your lives at risk and then doing what's best for our patients. And I commend everyone who is involved in this, doing something for patients, not for us. So this is definitely taking a toll on us. As I said, it started with 20, 40 patients. We did a good lockdown and then it went down to 20 patients per day. And then since April, we relaxed our restrictions. And then from May and June, it's a miserable trip until today. So we have been seeing anywhere, 100 to 150 patients in the hospitals. We have almost 1,800 ICU beds. I think we reached to 2,000 ICU beds in Houston. Still, we are at the edge now. A lot of sick patients, all ages, regardless of comorbidities. We cannot say only diabetics are at risk. We cannot say only old age patients are at risk because what we are seeing is that even young guys without diabetes, without hypertension, are dying on us almost every day. Coding on us.
It's the same here, yeah.
Yeah, yes, Zubair bhai. It's unfortunate, but initially we started, as Dr. Ubaid was suggesting, hydroxychloroquine, steroids. We did from the beginning. We started hydroxychloroquine in early March. After the data, we kind of backed off. We didn't know whether it worked or not. I myself used on myself when I was sick. We did not see any QT prolongations alone with hydroxychloroquine. But when we, started azithromycin, yes, we did. But we did not see any QT induced concerts or any deaths with that. So that I will mention clearly. We started on a lot of patients, lot meaning that every day 50 to 60 patients. So we did well with that. We didn't see any mortality, but because of the data, we kind of backed up. We were using steroids on in pulmonology community here in USA that we believe in steroids because of the data from MERS, SARS, H1N1. We know that this is going to work. So, hesitantly we have been starting steroids, but not at very high dosages. So azithromycin is always our pet drug to go, not just because of anti-infectious or because of atypical coverage, because of its immunomodulation
जी
as an anti-inflammatory. And also
जी
there is
जल्दी
also there is a data in, from SARS, that in even RSV viruses that azithromycin did show some improvement in mortality. So we extrapolated, so we used that. And then we started in early March with ritonavir combination as an antiviral. We didn't know whether it helped or not. We kind of backed up. Alhamdulillah, in March,
the
we
same
got,
issue here, yeah.
yeah, we got remdesivir right from the beginning. We got tocilizumab. We know that there is cytokine storm. Again, there are a lot of ifs and buts, and some people doesn't even believe cytokine storm. But if you look at the data, all those ferritin levels, IL-6 levels, they are all elevated. These patients are having high fevers. It makes sense. Maybe cytokine storm is real. So we did see definitely good
It is
benefit.
real, it is real. And
Yeah.
after giving tocilizumab, mashallah, patients have improved.
Oh,
Even
yes.
remdesivir, we have seen here
Yes.
and in India, patients
Yes.
have improved. I mean, the clinical progress was,
Yeah.
it slowed down and then slowly even intubation was prevented after
Yes.
giving
Yes.
remdesivir.
And I think Zubair bhai, timing is very important in that. So I'll tell
Yes.
you what our experience. So we had very limited dose of remdesivir in early March and tocilizumab, and we were rationing these medications only for ICU. So almost all the patients ended up dying with all of these things. No survival benefit with proning, with ECMO, everything. Then, as a group, Houston Critical Care Group, almost 300, 400 ICU doctors, then we said, what's going wrong? What's not right? We are using everything which are supposed to work. Then we thought maybe the timing is not right. So what we did, instead of using them in ICU only, we actually put them in, we started them on the floors where patients are requiring high flows, where they are not so sick. So because our understanding is that, see, if you have a cytokine storm, it will happen around 5 to 7 days. And if you have an infection, if you are very infectious, where you have a lot of viral load, it's early part of the disease, not when you end up in ICU after 7 to 10 days. Then we said, why don't we use these medications in patients who are, moderately sick, not severely, and see what happens. We also had a plasma at that time. So we started using these medications on patients who are on high flow, with bilateral disease, hypoxic, less than 92 or so, not so sick. Then we started using. We really felt that these medications works best when you start them early, not in the fibrotic stage where damage is already done by cytokine storm. So doing these things, we really decrease the mortality. So far, alhamdulillah, in my hospital, mortality is 6.3%. When compared to all over states, which is much lesser. I'm not saying it's just because of what we are doing. We are following certain protocols. So what I try to say is that after seeing hundreds of patients every day, now we are seeing 60, 70 patients each physician. It's too much for us. We are living our life in the hospital. Every day, I have at least 15 patients on high flow on the floor. They are supposed to be in ICU. There are some hospitals, people are managed in the room, on the floor with the ventilators because we don't have beds. So what I recommend from my experience is that, please start these medications if you have to early on. That's when you find the benefit. Now, unfortunately, what I'm seeing is that a lot of patients are coming after 10 days or 14 days. At that time, remdesivir is not going to help because you are already crossed that infectious stage. Already viral load is low. Cytokine storm is gone. We are seeing IL-6 levels of 30s with severe ARDS. When IL-6 is in 300, 400s, when you give tocilizumab or infliximab or something like that, it's helping us. As soon as we give, we see that fevers will be gone. The changes of X-ray may lag behind, but they really turn around. Oxygen requirements doesn't go up. Overall, I think there is no silver bullet. We are all excited as physicians saying that, hey, we have tocilizumab, we have remdesivir, we have plasma. I don't believe, Zubair, but honestly, in my opinion, after dealing with this for 5 months, almost probably I touched 500, 600 patients, not one thing works. It's a combination of things. And what I tell my colleagues, if you don't have these medications, that's okay. Supportive care, what we call is the simplest thing to do, works well. Look at them when you need to escalate the care, when you have to prone them, what's their fluid status, when to escalate the antibiotics, when to de-escalate the antibiotics. These are the most important things. If you hold them there, honestly, I'll tell you, there are so many patients every day I see can go home from high flow to nasal cannula without going to ICU, just with this supportive care. You can still do, Zubair, I think I'm not able to hear you. 1 second.
Just one question here for you.
You can hear you.
Now, these situations of critical illness, is there an ICU and also some patients who are critical lying on the floor there? So you guys in ICU, you pulmonologists, you are trained. My question is, the residents there or the non-ICU physicians, are they trained in managing those cases, identifying those cases?
So Zubair, basically we overlook, they will come and help us. They are actually surgeons who have
I
some.
mean, did you give any particular training to them, like online?
Yes, we will tell them what to look for. We are taking their help. At my hospital, fortunately, we are fine. But at our sister hospitals, yes, even surgical team are coming and helping them. Their pulmonary critical care guys are giving them guidelines, how to manage them, what to look for, when to call them. So yes, we are doing that.
Okay. The other question regarding tocilizumab. After giving tocilizumab, what was the incidence of infections?
I'm telling you, zero. This is my 5th month. I have been hearing from everyone. People are getting upset. Why the hell you're using tocilizumab? And I tell to them, hey, it is better than death. It is better than that you go on mechanical, because there are observational studies. I don't have randomized control study to argue with anyone. There are observational studies showing that these patients can avoid ventilator. So why don't you take it? It's better than death, better than the respiratory failure. I don't see, but in some of my colleagues' hospital, they did see some infections, some fungal infections, but nobody ended up dying so far I know.
Yeah. So as I told you,
one question. Do you check for this procalcitonin level before giving tocilizumab? Otherwise, you can use it blindly.
Yes. We are checking tocilizumab. See, one of the criteria we placed with tocilizumab, we are checking procalcitonin level. Also is that these patients are very less likely to present with leukocytosis. In our experience, it's almost zero. So if we see anyone coming with leukocytosis with this condition of COVID-19, definitely we'll be very cautious with them. To be honest with you, there are so many patients already on these medications, all those rheumatoid arthritis guys, all this, infliximab, they're fine. I don't believe there is an increased risk of infection. Probably steroids also cause the similar kind of issues with us. Now we are seeing more pneumothorax. I don't know what to make out of it. Is it because we are using steroids more? Is it because it's just the natural progression of the illness? Zubair, to be honest with you.
Yeah, I have seen, yes, small pneumothoracis, medium-sized pneumothoracis.
Yeah, I'm not saying chest tubes on them
And
alone.
one of our colleagues, his brother is admitted in the mom. He has pneumothorax, surgical emphysema, and pneumomediastin.
Yeah.
So, and it was all spontaneous. So this happens.
Then we are just managing them conservatively. They are doing okay. We are not using CPAP and BiPAP. So our goal is to stick them with high flow. If they are comfortable, most of these patients are happy hypoxic. We are leaving them alone, watching them closely. But if they are struggling from the day one, even on high flow for a little bit of hours, we are sending them to mechanical ventilation. We did use mechanical ventilation a whole lot in the beginning, but not anymore. But at the same time, we have to be very careful. We don't want to prolong it too much. If you are not seeing any change on bilateral infiltrates, 15 liters of high flow, if you are happy, hypoxic, you're good. But if you are struggling, no chance of using BiPAP. Only to transfer to ICU, we use BiPAP, but we intubate those patients. We are having a lot of issues. We did try BiPAP in between with the negative pressure rooms. What happening was, because of severe hypoxia, these patients are confused like hell. They are pulling their mask, they are coding and dying. So at least 4 or 5. Then we said, no, we are not doing BiPAP because these patients, even though they are young, they may be good because of hypoxia. They're confused. They're pulling the mask. So be careful with the BiPAPs. If you have the ability to intubate these patients, please do so.
Can I ask a question?
The outcome of intubation.
Outcome of intubation, since it's still very sad. It's not very good. Usually these patients are, I can say 50 to 60% of them can go on renal failure, dialysis, ECMO, septic shock, and ended up dying. Good 40 to 50% Zubair bhai, with all this ECMO, prone, steroid, remdesivir, they are making it. Very few patients ended up having tracheostomies. They did, but anyhow they didn't do well. If you are going to make out of ventilator, you should be in 1 to 10 days, 1 week to 10 days. That's it. If you are going more than that, probably you'll end up dying. As soon as we intubate, especially when we did early intubations, we saw a lot of renal failures, a lot of septic shocks, cardiogenic shocks. Now, which is lesser. I don't know whether the viral infections are milder or it's just we are getting better with this. I'm not sure.
The awareness of and how to manage, that is the reason, I think, because in US it was early intubation which was being done, and now they are avoiding intubation, and everywhere in the world they are avoiding intubation as much as possible. Non-invasive is being utilized, and the results are better or good, you can say.
What's the mode of death for these patients, Dr. Aziz? How they die? What's the mode of death? Cardiac death or respiratory?
Cardiogenic, unexplained cardiogenic shock. PES. One important thing, Noor, I forgot to tell is that we are seeing a lot of high D-dimers, as high as 80,000. It's so common to see 7, 10 of D-dimers. So we are anticoagulating these patients very carefully, though not in everyone. I'm not a big proponent of anticoagulating with the with the D-dimer of 7 or 10. Yes, I'm giving low inox 30 BID if you are having D-dimer more than 2, more than 3, maybe full anticoagulation depending on how you do. I scan them in and out with the D-dimer of 10, 15s, 20s. I scan their legs, I scan their chest. There are no clots, no clots.
They are microvascular thrombosis.
Yes, but Zubair bhai, on the same token, is becoming a double-edged sword. We are seeing patients with clots, not even hypoxic. They are coming for some other reason, COVID positive. They have clots everywhere. It's pretty strange. So you have to use judgment as a good doctor. That's why supportive care is the most important thing. See what you have to do for these patients. We are looking at the patients if they are not very mobile, young guys after critical care induced neuropathy, myopathy, they can barely walk. If their D-dimers are still more than 2, we are giving Eliquis or Xarelto 10 to 14 days. Some are giving for a month, depending on personal opinion. There's so much data. Recently, NYU Longhorn University, they did 70 of those autopsies. Almost everyone had clots. I don't know what to make out of it. But people argue that those 70 ended up dying, right? They are very sick ones. So why do you want to give anticoagulation to everyone, right? It makes sense if somebody argues like that. But it makes sense also to be cautious, give low dosages if you can, this anticoagulation. So it's like a standard for us to do that.
If people are coming back, people get infected, they recover, they go home, they're bouncing back with severe CVS, PEs, like DVTs. So this clotting activation is ongoing in the blood, and I think the surest way is to prevent it by using thromboprophylaxis at least for 2 to 3 weeks, especially with the people getting discharged on high D-dimers. I think it's a good policy.
Yeah, it makes sense. Yeah, these guys are not moving. Noor, when I had this COVID, I could not move out of my bed 10 to 11 days. After that 1 week, I was like, sitting on the couch, cannot do anything. I could not even climb first stairs of my home. So, it's a pretty severe illness. And my lungs were untouched when I had COVID. I did not have single event of cough or shortness of breath. My chest X's were clear, but I was so weak. I could not do. So now I think, clots are very common in these guys. They end up dying if you don't do anything. At least a little bit of anticoagulation would help.
Exactly. And the long-term sequelae of post-extubated patients, I'm sure, these people have long road to recovery, isn't it?
Oh, yeah. A lot of PTSD, lot of weakness. Yeah.
So one question to Dr. Razi. We have COVID patient almost 15 days, 20 days. Basically, is a doctor. I know he has a picture of like a fibrosis. So this COVID can cause lung fibrosis. The question. Second thing, how to manage this patient. Patient has normal X-ray before admission, 4 months before normal X-ray. Now he has lung fibrosis. So how to manage this patient?
Yes, it's a tough question, Obed bhai. I'm also dealing with that. Fortunately, since we have these patients since March, I have a lot of patients who come for the follow-up. Initially, they were looking very restrictive, like fibrotic, but eventually, especially the young guys, they are clearing up almost clean. So I don't know their lung function yet. I have to bring them back and check it. Initially, they were all restrictive. I did not even check their PFTs, but radiologically, they cleaned up very well after, I would say, 60 to 70 days. So I say, maybe they will have some issues on PFTs, but clinically, radiologically, after 2 or 3 months, those fibrotic changes in almost all of my patients, what I'm seeing here, are gone, especially in the younger ones. So I'm hopeful that it's not
How to
causing
manage these
long-lasting
3
damage.
months? Is there any data to steroids or what antifibrotic something?
We are not doing
Because
steroids for a long time. We are just using, oxygen support. All of these guys requiring oxygen for 4 to 8 weeks, and gradually they are coming off of it. We are just using basic inhalers to help them out. Apart from that, we are not doing anything active.
any
Just
role
manage.
of antifibrotic role?
Are there
No,
any studies on pirfenidone, colchicine?
No. So far, no. But as I said, fortunately, almost all of them had cleared their X-rays. I did not see any long-lasting damage. But I may be wrong too, because I'm not checking their PFTs. I did not check the PFTs because they were still symptomatic. I'm waiting. So I will update, how these guys will do. But I'm very happy that those fibrotic changes are almost all gone in my patients.
Thank you, Dr. Azit. Thanks for taking your valuable time out and
Thank you.
coming and at a very short notice to come and
Thank you.
share your experience. Just to take home points from Dr. Aziz, the timing is very crucial. Time your medications to save the lives. He touched on supportive care, such a huge thing. We physicians, we ignore it, but this is what's saving lives in America at the moment. And also the issue of spontaneous pneumothorax. Keep that in mind with patients in ICU on these nasty medications. Thanks, Dr. Aziz. Thank you very much.
Thank you very much.
Thank
Thanks a
you.
lot.
Thank you.
Yes.
Good to see you guys.
See you again.
Yes. So to move on, Dr. Zubair is going to present his talk on hematology and COVID-19. So Dr. Zubair is a consultant in hematology. He's trained, he's an alumni of Deccan Medical College as well. He's been working in Saudi Arabia from last almost 20 years. He did his internal medicine training and hematology fellowship following that. And he's also worked in King Faisal Specialist Hospital, which is a regional center for bone marrow transplantation for Saudi Arabia and also Middle East, if I must say. There's another center which I've known is the Cleveland Clinic, and King Faisal have extremely good results. Dr. Zubair is my senior by 2 years, and my attachment to Dr. Zubair goes before medical school. So I've known him from ever since I was a teenager. So it's an honor to share the platform with him. And the floor is for Dr. Zubair. Dr. Zubair, please go ahead.
Thank you very much. Assalamu alaikum, everyone. So let's start. So this is our medical college, and this is our hospital where we graduated. And so what tests usually are done in COVID-19 infection? So usually CBP with differential count, coagulation profile, which includes fibrinogen and D-dimer, and then blood chemistry, which includes urea electrolytes, creatinine, C-reactive protein, LFTs, cardiac enzymes, and troponin. And then chest X-ray is also done. And of course, for confirmation COVID-19, PCR test is also done. ECG is also done just to have as a baseline, or when you start certain medications which can cause QT prolongation. So in this slide, this is showing hematopoiesis, which occurs in our body. So this is the multipotent hematopoietic stem cell, which is commonly called as stem cell. Stem cell is self-regenerating. It divides and generates itself, and then it divides into two main lines. One is myeloid progenitor line, and the other is lymphoid progenitor line. So from the lymphoid progenitor line, natural killer cells, small lymphocytes are produced, and these small lymphocytes, they divide into T lymphocytes and B lymphocytes, and all of us know that B lymphocytes end up in plasma cells, and B lymphocytes are for humoral immunity, which secrete antibodies, and T lymphocytes are the cellular immunity. And there are natural killer cells also which are involved in the inflammation and infection. So coming to the myeloid progenitor side, on the left side, it is it gives rise to a megakaryocyte lineage, and then the erythroid series lineage, and then the myeloblast lineage, which give rise to all white blood cells with other than lymphocytes. So, and from these myeloblasts, from the megakaryocytes, of course, platelets are produced. Megakaryocytes are there sitting in the niches in the bone marrow. And then from there, the particles from the megakaryocyte large cell, the particles are released in blood, which are called platelets. Platelets are, they don't have nuclei. And next comes the RBCs, erythrocytes. These are produced in the bone marrow and released in the circulation. They don't have nuclei also. The next major cells are the myeloblasts, which are present in the bone marrows, and they produce all the different WBCs, which includes basophils, neutrophils, eosinophils, monocytes. And these monocytes, when they go into the tissues, they become macrophages. So am I audible to everyone?
Yes, you are. You're crystal clear. Please go ahead.
My slides are moving?
Yes, they are. Yes.
Okay. So in the CBC, what do you see? Usually hemoglobin, you look at hemoglobin, RBC count, and reticulocyte count. In COVID patients, usually the picture is normocytic, normochromic, where you will find normal hemoglobin, normal WBC, normal RBC, normal reticulocytes. So next, platelets. You can see most of the times normal platelets or elevated platelets, and in severe cases you may find thrombocytopenia. We as hematologists, we keep in mind an entity called pseudo thrombocytopenia, which occurs in, blood is drawn in EDTA tube, as I have shown here. This is the EDTA tube. So blood is drawn in this. Some persons in the population, EDTA antibodies form against platelets when the blood is drawn in the EDTA. So this happens in vitro, it is not in vivo. So we just keep this in mind that it could be pseudothrombocytopenia. And the other thing is the WBCs, which are the major cells which come in front line to fight different infections. So in most of the cases, you find normal WBC count, as Dr. Razi mentioned, and you will find almost all cases leukopenia, and there will be neutrophilia. I don't know, it is a relative neutrophilia, or it is due to the immune response, or it is due to secondary bacterial infection. We need to look at. So, so what happens is in COVID-19 infection, primarily there is viremia, where SARS-CoV-2 virus primarily affects the tissues, expressing high levels of ACE2 receptors, which includes the lungs, heart, and gastrointestinal tract. That is why, when patients become moderate and severe, they have lung involvement, and some of them have heart involvement. Dr. Nurullah will speak about that. And so many patients, they have like 28 to 30% patients, they have diarrhea, where the gastrointestinal tract is involved. Approximately 7 to 14 days from the onset of initial symptoms, there is, a surge in the clinical manifestations of the disease with a pronounced, pour in of systemic increase of inflammatory mediators and cytokines, which may even be characterized as cytokine storm, which we were discussing. So at this point, significant lymphopenia becomes evident. More of research is needed in this, and it has been shown that lymphocytes express ACE2 receptor on their surfaces. Thus, SARS-CoV virus may directly infect those cells and ultimately lead to their lysis. That is why you will find less of WBCs and especially less of lymphocytes. So the next thing is the cytokine storm, which is we will discuss this later. And moving on to the next slide, the genomic characterization of and epidemiology of this virus, the implications of this virus, origins and receptor. This was published in Lancet in last month. It showed that SARS-CoV-2 appears to preferentially target respiratory epithelium, where it enters host cells through the ACE2 receptor, similar to SARS-CoV virus, which happened more than a decade ago. So there is increased risk of ARDS during the disease course, which was significantly associated with increased neutrophils, decreased lymphocytes in a bivariate Cox regression analysis. Increased neutrophils were associated with increased risk of death, and we have seen in many patients. Tan et al., they have proposed a model based on lymphocyte counts and at 2 time points. At day 10 to 12 from the onset of symptoms, patients with less than 20% lymphocytes, and from day 17 to 19, less than 5%, they have the worst prognosis, and such patients, die. So I got this from an article, and this shows that different publications came out from, many publications came out from China in January, February, and March, and later on, in the subsequent months in the rest of the world, like US, Singapore, France, Germany, Italy. But I brought some studies here. If you look at this, there is almost all the studies, there is lymphopenia, and they say lymphocyte count less than 1,500 cells or less than 1,000 cells per liter, microliter. Lymphocytes treated as continuous variable in some studies, continuous variable in a bivariate Cox regression model. So lymphopenia was present in 83% of patients on admission, 92% of patients with the composite primary endpoint, that is admission to an intensive care unit, use of mechanical ventilation or death, presented with lymphopenia, versus 82% of patients without the primary endpoint. Severe cases presented lymphocytopenia more frequently versus non-severe cases. So, if patient has lymphopenia and you are seeing the patient in the community or in the hospital when you are in casualty or ER, or when you are in the wards, then you can assess the severity that this patient within days he may go and become severe. Initially, patients up to 7 to 8 days, they come with these initial symptoms. After 7 to 8 days, they progress. If the symptoms progress and the day 10 crosses, and then they enter the moderate or the severe phase. So I will be talking all this. My colleagues will be talking about this later on. So in this study, 85% of patients needing ICU care presented low lymphocyte count, 50 versus 54% of patients that did not need ICU care. And in this study, in Wuhan, in China, ICU cases presented with lower lymphocyte count versus non-ICU cases. Longitudinal decrease was noted in non-survivors. Lower lymphocyte count was associated with ARDS development in, again, another study in Wuhan, and the association with survival did not reach significance. So lymphopenia was present in 7 out of 16 patients. Median lymphocyte count was 1.1 in patients that required supplemental oxygen, and 1.2 in those that did not. So no statistical comparison was undertaken. So in subsequent slides, you can see here, and in United States and Washington, also they found low lymphocyte count noted in 14 out of 21 patients, which was 67% of critically ill patients. And in Washington State, in Seattle region, lymphocytopenia was common among 75% patients with median lymphocyte count of 720. And in another study, on admission, patient in the death group exhibited significantly lower lymphocyte count. also exhibited lower lymphocyte WBC ratio. The lymphocyte WBC ratio continued to decrease during hospitalization. So in this slide, you can see the thrombocytopenia. There are so many studies. Much of studies were done in China because they were having the large brunt of cases. Then you can find some studies in Singapore, some in USA, and I did not bring much studies. So if you look at these studies, thrombocytopenia was present in 36% of patients on admission, 46% of patients with composite primary endpoint admission, that is admission to ICU, use of ventilator or death, presented with thrombocytopenia versus 35% of patients without primary endpoint. So severe cases presented thrombocytopenia more versus non-severe cases of patients needing ICU care. And no significant, in the other study, no significant difference was noted in platelet count between ICU cases and non-ICU cases. Then in another study, platelets counts did not differ between patients with ARDS versus those without ARDS. Accordingly, no significant difference was noted in dead versus alive ARDS patients. So median count was 156 in one study, and most of the studies, it was more than 100. But once the disease progresses, it becomes severe. The low platelets counts less than 100 were also seen. So in this publication, thrombocytopenia is associated with severe coronavirus disease, a meta-analysis. So the results, 9 studies with 1,777 patients, 22% were severe disease, were included in the meta-analysis. The pooled analysis revealed that platelet count was significantly lower in patients with more severe COVID disease, with mean difference of 31. A group analysis comparing patients by survival found even lower platelet count was observed with mortality, without mean difference of 48 platelet count. In the 4 studies, with 1,427 patients, which reported data on rate of thrombocytopenia, a lower count was associated with over 5-fold enhanced risk of severe COVID-19. His conclusions were low platelet count is associated with increased risk of severe disease and mortality in patients with COVID-19 infection, and thus should serve as clinical indicator of worsening illness during hospitalization. And this slide shows the elevation of
Sir, you
CR.
have 5 minutes more.
Okay, I have a lot of slides to finish. CRP more than 10 and CRP more than 5 versus less than 5. And CRP treated as continuous variable, CRP treated as continuous variable in so many studies. So it was observed that disease severity was associated with elevated CRP in 81% of patients of severe cases versus 56% of non-severe cases with elevated CRP. The primary endpoint, composite endpoints were the same. Let's go to the other parameter, which is serum ferritin, more than 300 versus less than 300. So higher serum ferritin was associated with ARDS development. The trend of an association with survival did not reach significance. Higher serum ferritin level were associated with higher odds of death at the univariate analysis. So calcitonin level, disease severity was associated with elevated procalcitonin in 13% of patients of severe cases when compared to 3.7% of non-severe cases. Then the next variable is the D-dimer, more than 0.5 milligram per liter. Patients with composite primary endpoint, the D-dimer was frequently at 69% versus 44%. So accordingly, severe cases presented elevated D-dimer more frequently. So you can see so many studies from China. And so when you come to the coagulation tests, which includes PT, PTT, INR, if the platelet, along with the prolongation of all these, with if low platelet count and low fibrinogen level with high D-dimer, then it indicates DIC, and this indicates that patient has severe disease or he's late in the disease. So this paper was presented last month. So even it says that bleeding was very minimally seen in all these patients. Most of the cases, thrombosis was seen. Um, the cause was the COVID-19 associated coagulopathy is being used to describe coagulation changes in infected patients. The SARS-CoV-2 virus does not appear to have intrinsic procoagulant effects itself, although more information is needed. People started saying that this virus is thrombogenic or procoagulant. So this study says that intrinsically it is not procoagulant, whereas as in SARS-CoV patients, most likely a result of profound inflammatory response. So this leads to COVID-associated coagulopathy early in infection, reflects abnormalities in tests but does not fulfill the usual definition of clinical coagulopathy, where impaired ability to clot results in bleeding. Marked elevations in prothrombotic substrates may be balanced by both increasing thrombin generation and increased fibrinolysis. Unfortunately, data assessing thrombin generation and fibrinolysis are not available. So the findings are coagulopathy is manifest as elevated fibrinogen, elevated D-dimers. So usually you don't do fibrinogen level. Of course, you do D-dimers just to guide therapy. And there is minimal change in PT and PTT. And in initial stages, platelet count is not disturbed. Increasing IL-6 levels are correlated with increased fibrinogen levels. Coagulopathy appears to be related to severity of illness and resultant thromboinflammation and not intrinsic viral activity. Elevated D-dimer at admission is associated with increased mortality. Rising D-dimer after admission precedes multi-organ failure and overt DIC. So noted to start 4 days after admission in non-survivors. Longer duration of hospital stay associated with increasing D-dimer and development of sepsis physiology. Bleeding manifestations, as I told you, are not common despite coagulopathy. So what to do, which patients to do coagulation tests and what to do. So this table shows outpatient, no need to do coagulation tests once they are in, whether they are in the ward or in the ICU, they have confirmed VTE, presumed PE, or they are in RDS, need to do coagulation profile daily. And when to start standard dose VT prophylaxis as outpatient, consideration for use of standard VT prophylaxis in infected patients with morbid obesity or past history of VT. In such patients, it is recommended to use, or if the patients are immobile, this is the case. Otherwise, once patients are inpatient, start prophylactic VTE therapy. If they are in ICU or if they are in ARDS, and escalate the dose, as Dr. Rezi mentioned, they are doing. And therapeutic dose anticoagulation is given in confirmed VTE and if patients have presumed PE.
Sir, you have 2 minutes left, sir.
Okay, I need some more time, please. D-dimer is a specific antigen derived from the degradation of factor 13A cross-linked fibrin that is at the end of the coagulation cascade. So the D-dimer antigen measured in clinical samples is derived from the degradation of fibrin formed by the combined action of thrombin, factor 13A, and plasmin. So in this publication, earlier retrospective cohort studies of COVID patients admitted to hospital reported increased baseline D-dimer levels in 36% to 43%, particularly patients admitted in ICU. So if you look at this, dramatic elevations in D-dimer are the hallmark of laboratory abnormality of COVID, DIC. Patients with D-dimer more than 1 at admission are 20 times more likely to die than patients with lower D-dimer levels, and this is depicted in this graph. So this study is showing association between D-dimer levels and mortality in patients. So the results are they enrolled 1,355 hospitalized patients with critical COVID-19 patients. They were considered for final pool, and of these studies, D-dimer levels were found to be higher in non-survivors than in survivors. So the standard median difference in D-dimer levels between non-survivors and survivors was 3.5 gram per liter. And the Z score was 8.74 with a high heterogeneity across studies. So these are some studies here which show moderate to severely ill, critical ill patients, and the number of patients, and the age in median years, and the mortality. So if you look at the right side, the mortality is 14% or 11%, and somewhere 29%, somewhere it is 21%. So different mortalities have been seen. So despite high heterogeneity across included studies, the present pooled analysis indicates that D-dimer levels are significantly associated with the risk of mortality in COVID-19 patients. Early integration of D-dimer testing, which is rapid, inexpensive, and easily accessible biological test, can be useful to better risk stratify and manage patients. In conclusion, evidence has emerged that D-dimer testing in combination with clinical factors or other biomarkers may be useful to early stratify patients with COVID-19 admitted to hospital and to further individualize treatment. However, it seems premature to use D-dimer alone to guide clinical decision making. Further large population studies to validate
Okay, concluding
is
remarks,
needed.
please, Dr. Zubair. Concluding remarks.
So once patient comes, if he has higher, these patients, when patients having D-dimer more than 1 times upper limit of normal, more than 2 times upper limit of normal, and more than 4 times upper limit of normal. So these are the heparin users and non-heparin users. You can see the 20-day mortality. It is significantly low in heparin users. And this protocol is being followed in Ministry of Health in Saudi Arabia. And there are guidelines published by Government of India there. And you can look into it, how to give, anticoagulation to such patients prophylactically and therapeutically. So cardiac enzymes and the troponin will be discussed by Dr. Nurullah, cardiologist. Regarding CRP, alterations are detectable within 6 to 8 hours, and the peak values reached in 24 to 48 hours. Levels up to 1,000 folds the normal are associated with severe stimuli such as MI, major trauma surgery, neoplasms. CRP can be elevated in so many other conditions. CRP determination may replace the classical ER determination because prompt respond to changes in disease activity by CRP, and it's good correlation to ESR. So CRP levels in early stage of COVID-19, as you can see here in this study, elevated CRP levels and the just diameter of the largest lung lesion. So there is a correlation in these studies here. A relation between CRP levels and clinical severity and lung lesions. So this slide and this study depicts about this. Now let us go to the most complicated form of the disease, which ends in, if it is not managed properly, patients, they die because of this or other complications. So it is cytokine syndrome. So the pathogenesis is, it is a cytokine storm is a general term applied to maladaptive cytokine release in response to infection or other stimuli. So there is overwhelming inflammatory response from the body, and this cartoon depicts how this happens. In the lungs, the virus enters over here like this, and then it activates the dendritic cells and the macrophages, and the whole cascade of inflammatory response goes on in the body and especially in the lungs, which causes apoptosis of the cells and which leads to multi-organ failure and ARDS and so much of lung damage. and so much of damage occurs in the body. So when to consider cytokine storm, the criteria are one or more of the following. If IL-6 is more than 3 times of upper limit of normal, ferritin more than 300, or it is doubling within 24 hours. If ferritin more than 600, and at presentation the LDH is more than 250, or D-dimer is elevated more than 1, then it is considered as cytokine storm. High platelet to lymphocyte ratio may indicate a more pronounced cytokine storm due to enhanced platelet activation. This is also another indicator. So, thank you.
Thank you very much, Dr. Zubair. I think it was a very exhaustive talk, and I think in interest of time, I think we will move forward. If that's okay. I think the important thing, take-home message from Dr. Zubair's talk is D-dimers. Make sure that you keep checking them on a daily basis for the inpatients. Second thing was, do not consider any coagulation tests with outpatient, as they are pretty much safe to carry on. Dr. Zubair, your talk has generated a lot of questions. If you can look into the question and answers panel, because there are a lot of people are asking about various
Sure.
questions regarding the management of the clotting and other things. So
All right.
I'll just upload my presentation, and in the meantime, so let me just get my first slide. Okay, so can everyone see my screen? Okay, so I'll just introduce myself. I'm Dr. Noor Muhammad. I'm working as a cardiologist in western region of Abu Dhabi in a city called Medina Zayed. Previously to coming here, I've spent a couple of years in Saudi Arabia, Riyadh, and before that I did most of my training in internal medicine and cardiology in England. I spent around 16 years in West Midlands area. So to move forward, to have any disease to reach a pandemic level, you need a perfect combination of an agent, host, and environment. And I think the COVID-19 is a perfect example for that. According to the last WHO report, we had 500,000 reported deaths. I'm sure the unofficial number is much larger than that. And only time will tell how long these effects are going to last for. So the origin of quarantine, and the social isolation is not a new term. This was actually coined and actually promoted by an Arab scholar almost 1,000 years back. His name is Ibn Sina. He was the first person who noted that the disease, communicable diseases, spread from person to person, and he came with the method of isolating people for 40 days. So this in Arabic, this 40 days is called Arba'in. So the one who knows Arabic, they understand it. And the Italians took it from this concept and took it and named it as quarantina. That's where the term of quarantine comes from. So moving forward, we know that majority of people have a low case fatality rate, but a small proportion of people have a high, the high end of the spectrum, and which are basically, they end up with high mortality in ICU, multi-organ failure, ARDS, and cardiac mode of death, and they degenerate very rapidly. And most of these patients, as I was discussing with my colleague from America, they have a cardiac mode of death. So moving forward, we all know, we have seen all these nasty pictures of CT scan of nodular obesities and peripheral stigmata. Peripheral, as the CT scan, the lower CT scan has clearly shown that in the peripheral. So I think if someone shows you or us these pictures in 100 years time from now, and the COVID-19 will be one of the differential diagnoses. So moving forward, we also seen how the florid pneumonitis pictures looks like, and they're destroying the major part of the lungs. So what's the learning outcome from today's talk? So we're going to talk about how to manage the bread and butter cases of cardiovascular cases during the current pandemic, and what's the potential role of biomarkers in predicting prognosis. I hope I can convince my fellow panelists and also the attendees the important role the troponins and the natriuretic peptide are playing, but it's been underreported in the COVID-19 patients. And also there has been some controversy regarding the ACE2 levels, ACE and ACE inhibitors and COVID-19. So I'm going to touch a few slides on these. And I'm going to touch something on QT prolongation and the potential side effects in COVID patients if you start them on hydroxychloroquine, azithromycin, and antiviral drugs. And last but not the least, case studies, if I can get some time towards the end, my own personal experience with these patients. So what's the case fatality rate and what's the risk? Some of the questions which came yesterday was which group of patients have a high risk. So clearly in your diabetics, hypertensive, in the previous history of cardiovascular disease, if you have lung disease and cancers, they have a high odds ratio of dying from this disease compared to the other coronaviruses, because coronavirus is nothing new. The SARS, MERS from the previously came to Saudi Arabia, Hong Kong, they are all coronaviruses. But what's so special about COVID-19 is, they are potentially fatal in this group of patients. So, have a look at this data from the WHO. If you have a cardiovascular disease, you have a 10% mortality rate compared to the general population where the mortality is only 2 to 3%. So it is pretty obvious, like, someone having cardiovascular diabetics, chronic lung disease, they have, and hypertensive, they have a high proportion death rate compared to the general population. So recently, this is one of the meta-analysis which got published from University of Leicester, where I come from. So they looked into, they looked into about 23 or 24 studies of mortality and COVID-19. All of them basically have a high odds ratio, diabetics, hypertensive. So the theme is quite repetitive that, if you are diabetic, if you have all these risk factors, you have a higher chance of mortality. So yes, we know that COVID-19 patient majority are present with fever, fatigue, chills, but if you see, some patients, 1 in 5 will have dyspnea as presentation. So you'll have to think in that differential diagnosis. Even the patient with heart failure have dyspnea. So we don't know which is heart failure, which is COVID-19. So you have to look into the context of the clinical picture. So I hope, there is a very huge compelling evidence for the biomarkers of cardiac biomarkers to be included in this same class as interleukins, D dimers, ferritin, and LDH. So moving forward, so initial symptoms of COVID-19 can mimic cardiovascular symptoms like breathlessness, chest pain. That can be the initial presentation. That's how the cardiac patients present. So, and also sometimes the cardiac manifestation could be the first manifestation of COVID-19. I have seen patients coming with STEMIs. I've seen patients coming with myocarditis as a part and parcel of COVID-19. That's the first presentation. So the important trick is that you have to treat both the diseases to have a better outcome. If you're treating only one, if not treating the other one, then you're doing a disfavor to the patient management. You're inviting high mortality for your patient. I'm going to touch a few slides on STEMIs and auto-hospital cardiac arrest, what the current guideline says. And also, we have resource allocation because, we have limited number of patients, limited number of doctors, nurses, ICU beds, but we are getting overwhelming patients coming to the hospital. So, and also there's a huge issue of this clean ICU and CCU. So someone coming with chest pain, STEMI, non-COVID, and also someone coming with COVID, you can't keep them in the same unit. You have to look for a clean ICU and CCU. So mechanism of cardiac injury. So basically the hearts get affected by 3 ways. Either you get affected directly from the virus going and attacking the myocardium, where the patient comes with fulminant myocarditis, or as a part of, as a cytokine release storm, all these interleukins and goes and attack the cardiac myocardium, and you get myocardial depression, and you end up having ACS, or you can have what we call is type 2 myocardial infarction because of oxygen demand mismatch from the respiratory failure, hypoxemia. So how does it manifest? Either you can have asymptomatic troponin leak, you can have cardiac arrhythmias, you can die from there. The commonest cardiac arrhythmia which happens in ICU is atrial fibrillation, which can happen because of hypoxia. We all know that people who work in ICU, they can relate with what I'm mentioning. Patient can come with acute myocardial infarction, either type 1 or type 2. Type 1 is basically you have a thrombus, you have a plaque rupture, and patient come with full-blown STEMI. And type 2 is the oxygen supply mismatch demand. So moving forward, so this is how the manifestations are, which I have been alluding in my previous slides. ACS, prothrombotic type 1. Type 2 is, type 1 is plaque rupture. Type 2 is oxygen supply and demand mismatch. Acute heart failure, myocarditis, or there's also an element of stress-induced cardiomyopathy where patients have a combination of both viral myocarditis and stress-induced cardiomyopathy. And third modality is cardiac arrest and cardiac arrhythmias. because of a lot of factors, metabolic and all your electrolytes imbalance, hypokalemia, hypomagnesemia, hypoxia, drug-induced QT prolongation had a special mention for COVID-19. Cardiogenic shock can be the first manifestation. And also we know that, what the clottings can do for PEs and right heart strain, because these patients are immobilized, especially the hospitalized patient. There's vascular inflammation and endothelial dysfunction. So this is, I think the previous speakers have already alluded to this graph where there is a lymphopenia in the stage, then you go through a stage where there's abnormal chest imaging, and finally, if you're unlucky to reach to the right hand corner of the slide, then you end up having cytokine release storm, and all these inflammatory biomarkers start playing up in your body. So suppose someone coming with chest pain to your emergency, we don't know whether this is a true STEMI or pseudo-STEMI, because we have seen cases coming, myocarditis coming with ST elevation is not unusual, because myocarditis can also present with ST elevation, and people who don't have access to a primary cath lab, it's important that you don't thrombolize this patient. So something called point of care ultrasound is very helpful. You can just do a quick echo, make sure that you put all your PPEs and have a look whether the myocardium is globally dyskinetic, globally regional wall motion, or is a regional, which is a part and parcel of true STEMI. And also, if you're thinking of taking this patient for an emergency primary coronary stenting, you have to look for your safety of your staff as well. So how do you triage these patients? So when the patient comes with chest pain and you confirm this is STEMI or a high risk end STEMI, the treatment is still the same. The patient goes to the cath lab. If the patient has an end STEMI, which is basically it's not a full-blown infarction, but you have high risk features like patient is in heart failure, patient has got a dangerous electrical arrhythmias, and his chest pain is and also ECG is very abnormal, then it's a very good mandate to take these patients to the early PCI. So what do you do next? Once the patient has a PCI, then we don't know what's the COVID status then. So you have to treat him as a suspected COVID, and you have to put him in a negative pressure room until we get the COVID results back. So this is what the European Society of PCI expert consensus came, that you categorize patient into emergency, urgent, lower priority, and elective. So all those emergency, they have to go and have an emergency primary PCI. So this is, suppose an example, patients coming to, is a self-presenter to your hospital, and patient is in the hospital is a non-cath lab hospital. You have to look whether this patient can be shifted safely to a PCI capable hospital within limited allocated time as recommended by all the societies, which is 60 to 90 minutes. Then you should shift the patient to a primary PCI center. If you can't do that, then you thrombolize the patient and then shift in safely. Important thing is to make sure that you treat all the suspected cardiac patients who present with chest pain as COVID positive until and unless proven otherwise. And perform lysis only if there is no contraindication. It's very, very important you take a thorough history. That's the trick. And also rely on the point of care ultrasound in your emergencies. And in fact, the societies are also telling not to do an echocardiogram post-procedure, just do an LV angiogram at the same time as primary PCI. So this is, I think I already covered this earlier, so I'm not going to spend much time. High-risk patient in end STEMIs, treat them as STEMIs and take them for cath lab. Low-risk patients, look for some non-invasive testing like cardiac CT, which is a very good imaging modality. And very low-risk patient, just stick with medications. So moving forward, although most of my colleagues in medicine and other specialties were busy when the COVID pandemic started, for some reason, the intervention cardiologists were twiddling their thumbs from last couple of months. So in fact, an intervention cardiologist from America wrote a very good article in New York Times, where have all the heart attacks gone? Why suddenly, for some reason, we as intervention community, we started seeing less patients coming with the heart attacks. Does it mean that people are having less heart attacks? No, they're not. People are having heart attacks, and still, although we are going through a pandemic, more people are dying of heart attacks than people dying from the COVID-19. So what the European Society of Cardiology did was they did a survey of all the interventionists across the globe, I mean, there were 3,000 total survey participants, and by far the majority of them have came with the same observation that the STEMI cases have gone down. And I'm going to share the statistics from my cath lab. So we commissioned the cath lab in 2019. So we started doing cases in 2019. So I did a comparison of last 6 months, the first 6 months of 2019 with the first 6 months of 2020. You can clearly see that the green line of 2019 was going up. And I was expecting that our figures for 2020 would also go up like this. But some reason in March, our figures went down south, and this is where the UAE lockdown happened. The UAE pandemic started, so our numbers plummeted quite drastically in month of May, but numbers started picking up. Now the pandemic is controlled in UAE, so we did about 11 cases compared to 25 what we did in 2019. So this concept of STEMIs not coming to the hospital, and so the group from Italy, from Lombardy, they were the first one who came with this very nice study, which basically they shared that they did for 1 month, the STEMIs they said the majority of STEMIs came as the COVID positive. That was the first presentation of these COVID patients. And unfortunately, 40% of the patients died of, so this was the first time the medical community started recognizing that STEMIs can be the first manifestation of COVID patient, and it's a high mortality figure as well. And all the patients underwent through a primary PCI strategy. So what we followed in my center is that we are a 16-bedded CCU, ICU. We are fully equipped, and we follow hub and spoke model. We have 5 referring hospitals in the region, and we triage the patients in STEMI, and we have 2 negative isolation rooms, and our COVID results time is around 24 hours. And we don't perform routine echoes unless we feel that the patient's condition is deteriorating, as I alluded earlier. And we also are involved in telemedicine clinic, and where we take a phone call from the patient, and we prescribe medications online. And we have also deferred our routine transthoracic and DSC service during the pandemic. So far, in last 4 months, I personally have not done any transthoracic or a DSC routine DSC procedures. And now that the pandemic settling down in UAE, what we're doing now is that we are slowly getting the people confidence coming back. They're coming to the clinics. So if I need to list any procedure for transesophageal echo or an elective angiography, I take a COVID sample and I ring them within 48 hours. If they are negative, they're clean, then we plan the procedure. So I'm also going to share the ICU statistics from our center. So not many people do that, but I had access to this statistics because I was working as a COVID coordinator for my center. So number of people who went through our ICU was 124, and out of those, about 24% patients had acute kidney injury, and roughly around 24 patients from the 124, which is like 20% patients, went on mechanical ventilator, and we had 50% mortality rate. So, which is pretty much okay in the sense, like earlier we used to hear that, the mortality rate once you go on ventilator is almost 80%, 90%, but compared to that, our figures are pretty much okay. Unfortunately, but these people who go on ventilator, they have a higher rate of acute kidney injury. And also, this is a very nice review article linking COVID-19 with heart failure, because there's a lot of overlap between symptoms. As if the cartoon which I've alluded earlier, 20% of patients present with dyspnea. So you have to take a very thorough history, and you have to go through all these factors to make sure that you rule out presence or absence of COVID-19 in these patients. So this few slides on controversy regarding the ACE2 levels and ACE inhibitors. So the earliest in March, April time, there was this article got published in New England Journal of Medicine regarding the serum ACE2 levels. I just want to give you a bit of background regarding ACE2 levels. So these receptors are mostly found in lungs, and heart and kidneys and vascular endothelium. And for some reason, this S protein goes and attached to the ACE2 levels and is what you call endocytosis. So they have a propensity to go and attach themselves to the serum ACE2 levels. And there are actually 2 school of thoughts regarding this. So why there is a relation between this ACE2 and angiotensin 2? By attaching to ACE2 levels, the virus is downgrading these receptors. But because ACE2 has relation with angiotensin 2, they have a negative feedback loop with each other. Because ACE2 levels goes down, the angiotensin 2 levels goes up. And we know that angiotensin is a very pro-inflammatory, it leads to pro-thrombotic vasoconstriction. And CREB and ACE inhibitors also involved with this angiotensin 2 inhibition. So there is a negative feedback loop. And this one theory is that because ACE inhibitors increases ACE2 levels, and hence the virus is attached more to the ACE2 and leads to more destruction. The other theory is that the ACE2 levels goes down, and that's the reason why angiotensin 2 level goes up. But this was only a theoretical experimental theory, because subsequently what happened was, the observational studies came out from across the globe and also China, and they looked into the patients who were hospitalized with COVID-19, hypertensive patients who were taking this ACE and ARBs, and they could not actually come with this scientific explanation that it is causing a high mortality. So what the current recommendations from American Heart Association, ESC, British Cardiac Society, they're all saying that do not stop any of these medications. In fact, this Wuhan study of more than 1,000 patients, they came with the conclusion that using ACE and ARBs is actually associated with low risk of COVID-19 infections and complications and death. So please, if you have anyone on these medications, if they are being admitted, if you are seeing them in the community, do not stop them for any reason, just because some experimental data came out. So this is what the current recommendations are. At present, there is no evidence to abandon renin-angiotensin. Moving on, 3 or 4 slides on troponin and BNPs in the current pandemic. Troponin can be used as a prognostic marker and also as and help in the differential diagnosis as well. I hope I can convince you that to include troponin in your biomarkers panel. We know that troponitis happens for a lot of reasons, even in healthy patients. Some of you, if you're working in emergencies, people take troponin, and you are in dilemma, like some troponin leak happens, patient does not have any symptoms, what to do. So COVID-19 is not an exception. If you have a mild increase, you don't have to worry much about it. But if you have a seriously high increased troponin levels, you have to think about type 1 myocardial infarction. You have to think about myocarditis, Takotsubo cardiomyopathy, cardiogenic shock. And if they have, and also you have to think about PEs and heart failures and ARDS, because troponin level goes up. As earlier I have alluded that COVID-19 goes and attacks the myocardium in 3 different ways. So this is a wide differential diagnosis for the troponin rise in COVID-19 patient, and you have to think about non-COVID differential diagnosis as well. So the earlier study from Wuhan has actually, they were the first one who actually alluded to this COVID-19 and troponin. So basically, non-survivors, troponin T levels are higher compared to survivors. And also this another very nice, elegant study. So they looked at the troponin levels between the survivors and non-survivors. In the survivors, they have a pretty much blunted troponin levels during the patient admission. Whereas in non-survivors, if you can see, the troponin, there's an incremental increase in troponin from the day 4 to day 19. So and this is another study which looked at the inpatient mortality at the admission troponin levels. The one with troponin negative, this is the Kaplan-Meier survival curve. So basically, if you have number close to 1, you have a good survival. If you have number going down, that means that you have survival event-free rate is very, very less. So if troponin negative, you have pretty much good inpatient mortality compared to troponin positive. Your survival only like 0.5%, which is 50% mortality. Another study, similar study, they went through 30 days inpatient mortality. They can prove that even the patient stays for 30 days, troponin can be used as a prognostic marker along with your other biomarkers. So this another study which came from Wuhan is a very nice, elegant study. They looked into patients. So what they did was they divided patients into with cardiovascular disease, without cardiovascular disease, with elevated troponin, without elevated troponin. So the bottom half of the graph, if I can bring your attention, the purple line. So this is purple line without CVD and normal troponin, your mortality figures is only 7% compared to the one with, if you have a background of cardiovascular disease and you have elevated troponin, your mortality goes up quite exponential from 7 to almost 70%. So troponins can be used for risk stratification. So, okay. So moving forward. So this is a very important slide. So all this panel of biomarkers, interleukin-6, ferritins, your CRPs. So basically, troponins can be included for risk stratification. Have a look at this slide C. So as I was alluding earlier, a blue blunted line demonstrate that troponin levels are pretty much static during the admission compared to the incremental increase of troponin, and see the mortality figures. So it's pretty much self-explanatory. I don't have to. I think I have given a very good argument for using troponin as a prognostic marker in addition to your CRPs and interleukins. So another study of a systematic review of troponins and relation with severe disease and odds ratio of death. So moving forward, as you can see from left to right, so you're moving from day 0 to day 28. And if I can highlight the color, which is yellow, means you're okay, and if you're in the red zone, that means you're deteriorating. You're moving to the right and corner of the graph of the core of the cytokine release storm. So basically, troponin levels goes up, and there's a high risk of your coagulopathy, ARDS, vasculitis, a risk of heart failure. You can include the nitrouritic peptides as well into the panel of biomarkers along with your cytokines. So moving forward, so this is a very nice review article was written by the group from Cleveland Clinic, and in fact the first author, Bassam, he works in the Abu Dhabi branch, and basically they came up with this conclusion that serial monitoring following admission with COVID-19 patients, if you can see any rising trend, that means the patients are getting sick and you have to do something more about it. Remember what Dr. Razi has earlier mentioned, the timing of medication is very important. If you want to save your patients, the timing is extremely important, and troponin can be used with your other biomarkers. And do not use the levels in isolation. Just troponin elevation without any symptoms of or signs of myocarditis or STEMIs or CRP rising or interleukin rising doesn't mean anything. You have to add 1 + 1 = 2, is not 3. And so what does the societies recommend? Unfortunately, they are slightly behind compared to the data which is out, that they are suggesting that measure troponin only if you're suspecting type 1 infarct or you're suspecting new onset LV dysfunction. And also same with nitrouritic peptides as well. So moving on, few slides on D-dimers. Is nice. This is one of the earliest talks, earlier studies which established D-dimers as a prognostic marker was from China. So this is a ROC curve, which basically the cutoff was 2 micrograms. So what they did was they dichotomized patients below 2 and above 2. If your D-dimer levels are below 2 at admission, your survival probability is more or less 100%, compared to if you have D-dimers more than 2, your survival probability goes down drastically with the hazard
We
rate.
are running out of the time, sir.
Sorry, okay. So move on. So D-dimers, yes, it is a very, very important prognostic marker. So this graph of this is actually from our patient from the hospital. Patient was admitted on 6th, and if you can follow the D-dimers level from right to left, look at these D-dimer levels. Wow, they jumped up from 8 to 11. Finally, they jumped to 64. You can imagine how sticky the blood is inside the patient's circulation. Unfortunately, this patient died. So I'm going to skip these 2 slides. And also, I think cardiac arrhythmia, I think important. Let's move on to the hydroxychloroquine and chloroquine, because a lot of media generation, this medicine have generated a lot of talks, a lot of tweets, the infamous tweet by the famous person, and led to the people started eating this medication like sugar pills. And so few slides on this one. So actually, when you are starting hydroxychloroquine, you have to look at this risk score. This was developed by the author called Tisdale. So you have to have this risk score in front of you when you are actually thinking of starting hydroxychloroquine. And also, second thing is the FDA came up with this recommendation that hydroxychloroquine should not be started in the outpatient community. It has to be inpatient because of high risk of QT prolongation, people dying of torsades de pointes and VT and VF. So two important publications regarding this QT prolongation, combination of hydroxychloroquine and azithromycin. Before I discuss that, I want to tell you that hydroxychloroquine has a half-life of 22 days. Combining hydroxychloroquine and macrolides is a potentially lethal combination, especially for heart patients with cardiovascular disease. We know that, you know, there are 50% cardiovascular patients with COVID-19. So you have to make sure that you check your renal functions, all your electrolytes, your thyroid function, your heart rate, and everything has to be included in your panel when you are actually starting this very nasty medications. So what they did, so this was a single center study, observational study, 90 patients, 50 of them were on dual antiplatelet dual therapy, and 50% were hypertensive, 30% diabetics. The median baseline before they started the medication QTC was 450, and 1 in 5 developed QT prolongation of more than 500. And your risk goes higher if you are taking loop diuretics, and if your baseline QTC is more than 450. And there was a 10% discontinuation rate because of nausea, hypoglycemia, and torsade points. So you have to exercise a very, very high vigilance, like, you know, for all these risk factors before you start these medications. Another paper which came out looking at the mortality of combining these two medications. This is an observational study from New York of around 1,000 patients from 25 hospitals. So what they did was they looked through all these potential complications and have a look at this cardiac arrest. If you combine, they divided patients in the 4 groups. So basically, if you combine on hydroxychloroquine and azithromycin, you have a 15% risk of having a cardiac arrest compared to if you're not on either drug. So again, you know, arrhythmias, QT prolongation, similar risk. So you have to keep this in mind when you are starting these medications. So I want to share this very important ECG. If I say these 2 ECGs belong to the same patient, okay? So this first ECG was before hydroxychloroquine, second ECG was post hydroxychloroquine. So this lady came with non-specific symptoms of fatigue, lethargy. 2 COVID-19 tests were negative. So this patient initially was bradycardic. She had a left anterior hemiblock and a right bundle branch lung morphology. She was just bradycardic around 55 to 60 beats per minute. 3 weeks, I don't think even 3 weeks, like 2 weeks down the line, she came with dizziness, exertion, breathlessness. She said, you know, she is feeling dizzy. So she went from just bradycardic to a seriously bradycardic. Heart rate went down, plummeted to 38. If you can see this drop P waves here, she became a Mobus type 2 AV block. So I think I don't need to explain any further how serious this medication is. So the ESC came up with these guidelines. I don't want to go in detail. This is basically repetition what I've alluded earlier. You have to do your electrolyte panels. You have to do a baseline ECG. You monitor the ECG first 2 to 3 days. And they also are recommending that you have to admit this patient when you're starting this medication. So moving on, I think I will skip this slide, and also I will skip it. So I will share a couple of interesting case studies which came to our hospital. So if you can look at this ECG, it's pretty much self-explanatory. This patient have ST elevation in the anterior precordial leads. So which is a 46-year-old male. He came with chest pain, no previous cardiac history. So he had this ST elevation in the anterior leads. If you have a very good eye, he's got ST elevation in inferior leads as well, which is very, very uncommon. So normally, you know, patient come with territorial, either ST elevation inferior, posterior, anterior, but it's very unusual to have ST elevation in both inferior and anterior leads. Anyway, what we did was we took the patient to the cath lab, and the first picture we took from the right coronary artery, patient had a filling defect in the distal right coronary artery. Although you can see a filling in the branches PDA and PLV, but there was a thrombus in the RCA. There's another picture of the left system. Normally there should be a big LAD, left anterior descending artery in the front of the heart, which was missing. This artery was completely blocked with thrombus. So what we did, we went with a wire. This is what we extracted from there. It's a big snake, basically a big thrombus. We extracted, we restored the flow, we stented the LAD. This is how it looks like. This is how it should look like. And also on the way out, we stented the distal RCA. So this was, at this time, we didn't know patient was COVID positive. We just came with a chest pain. Patient did not complain of any fatigue, viral symptoms. The next day, the patient, we did some, as a default, patient was stopped for COVID-19 on the day of procedure. He came positive the next day. You can see his CRP was high, D-dimers was high, and also his, the remaining biomarkers, were also high. So what we did was we treated him with our usual antiplatelets. We got some hydroxychloroquine, antivirals, Clexane, and patient became negative, and he was discharged on day 4. Another case study, this is of one of our ICU patients. We can clearly see he's got a florid COVID pneumonitis, he's got a central line, he's got an endotracheal tube, and this is his CT scan, peripheral stigmata of COVID-19. So, so this patient became unwell. This ECG changed from this to this. So basically, he's got a biphasic in the top panel. He has a biphasic T-wave changes, and at some stage during his admission, when he was intubated in ICU, he became more hypoxic, and they did an ECG, and this ECG is a new onset left bundle. His troponin jumped from 16 to 334. So my colleague was called, and he went and had a look at the patient. He did a bedside echo. Patient had a global LV dysfunction, and that's how he came with the diagnosis of viral myocarditis. So he was given supportive treatment. Unfortunately, this patient died. He could not make it. So this another case report which came up in the literature regarding COVID myocarditis. This patient was lucky. He survived. As you can see, the bed panel, the troponin went up. Then with treatment, the troponin levels come down and parallel with CRP as well. I think I will move on from this slide. So this is a nice review article on COVID-19 and myocarditis. That's what they recommend as supportive care, but also consider systemic steroids and also tocilizumab, interleukin-6 inhibitor. So closing remarks. So if you have a STEMI and STEMI, think of primary PCI and prefer over thrombolysis. Myocardial injury in COVID-19 patients is associated with worse prognosis. So keep your troponins in your biomarkers panel. You know, if there are rising trend, think there's something going wrong. I've also touched on D-dimer levels and importance of thromboprophylaxis. Do not stop your ACE inhibitors. If you're going to start your hydroxychloroquine and azithromycin, think of QT prolongation, think of torsades, think of arrhythmias, think of death. And also immunosuppression for myocarditis patient. And the recovery trial has established the role of, a very important role of dexamethasone in the intubated patients. And also think of mechanical circulatory supports like Impella, balloon pump, ECMOs for those patients who has confirmed myocarditis and poor LVs, they're not improving. A few more slides on resuscitation, because I'm going to present the next video as well. I think I'm not sure whether the Dr. Zubair and Dr. Ubaid can allow me to present 2 slides, just a couple of slides on. So what the AHA is saying that, you know, if you have a suspected COVID-19 patient had a cardiac arrest, make sure that you cover your face, you cover the patient face. Do not do mouth-to-mouth resuscitation, just do hand-only CPR, standard hand-only CPR of 100 to 120 compressions per minute, and use AED if there is a shockable rhythm until, you know, patient get seen by a paramedic or patient get taken to the hospital. 2 more slides on, because we are actually treating all these ICU patients in prone position, and there was a lot of debate in our hospital, like what to do. You know, if this some patient needs an ECG, we can't keep changing the position again and again. So I just want to give you a brief idea about, you know, how to place the leads. So, you know, instead of putting the leads in the front, you have to, as a mirror, you know, you have to put the leads in the back side of the patient. This picture is self-explanatory. So the only leads which are actually changing is the precordial leads, V1 to V4. V5, V6 more or less the same. The limb leads more or less the same. So this is your normal ECG when you're in a supine position. The ECG leads in the front of your chest, and compared to this ECG, which in the prone position, the only thing you will see the change is the low amplitude of the precordial leads from V1 to V3. Okay. I think that's it. I think. Sorry. Hello. I think that's the end of my discussion. I think I'll stop here. I'll open the panel for discussion.
So regarding this CPR, Dr. Nurullah,
yes,
I will postpone to last day.
Yeah, I think I agree, because we are running short of time, yeah. And I think I kind of went through a very speed rail, to be honest, because in the interest of time. I think, shall we open the panel for discussion, or you just want to pick up any of the questions raised by the
we have some questions here. one or two questions for Dr. Obed, and there are a lot of questions for you, and so many questions for me. I tried to answer them.
Let's pick up the important one.
What is the basis of using azithromycin at start of infection? This is for Dr. Obed.
Yes, as Dr. Ravi told clearly, azithromycin is not just antibiotics. It's an anti-inflammatory antibiotic, also immune modulator. So there are many data supporting the use of azithromycin, especially in the early stages. The patient may respond, and they may have this other effect of anti-inflammatory and immune modulation. So there is data supporting the use of azithromycin, especially in early stage.
So another question for you, Dr. Obed. Can a diabetic hypertensive patient with mild ground glass changes on CT scan with normal SpO2 be started on steroids?
No, answer is no. The indication of steroids only is hypoxia. So there is no hypoxia, we should try to avoid the steroids. Because I told you, because this, especially early stage, again, is viremia. So it may cause immune suppression, the viremia will have an upper hand to spread and the disease may progress.
This question is for Dr. Nurullah. Is it possible that patient presents with cardiac symptoms or MIs while remaining completely absent or very mild respiratory symptoms?
Yes, I think I've shown a couple of case examples. It's very likely you can do that. Patient can come with full-blown STEMI, myocarditis, cardiac arrhythmias, cardiogenic shock. He can present at any point of the symptom profile.
One question to Norola, this is a practical question. Here using in India this chloroquine as like water for many years. But why this phobia of chloroquine using this causing prolonged QT? So what do you think about this?
Because
Here
I
in
think,
India,
I think the patient characteristics of the malaria and the COVID-19, they are different.
Yes.
You know, you have to be extra cautious with people who are diabetics, who are hypertensive, who are taking all these beta blockers and the rate limiting medications. And that's the reason why you have to be extra cautious. That's what the FDA is saying, that is a, you know, a lot of, we don't know because previously we don't have a data about these malarial patients that started on, and also for malaria, the short is a very short course. Whereas, you know, for COVID-19, you know, we have been, you know, putting patients for 8 to 10 days, sometimes 2 weeks, and without any monitoring ECGs, especially in the community, is a very serious thing, because, you know, from India, we don't have any case reports coming out that unexplained deaths happening in the community. And, you know, we need to have studies about this COVID-19 patient going on hydroxychloroquine, azithromycin combination in cardiac risk factors patient, and the risk of arrhythmias and death.
So there is a question for Dr. Nurullah: how to differentiate between acute LVF and respiratory failure due to COVID?
I think let's start with the clinical symptoms. I think initially, you know, you have to look for, like, you know, how's the duration of symptoms and how long it took over, whether the patient had fever or not. You can have a mixed picture of heart failure as well as COVID-19, because time often we have seen that pneumonitis can lead to heart failure with myocarditis as well. So the history is very important. Use the bedside echo, point of care ultrasound. If you can do a Swan-Ganz catheter or central line, you can see the PA pressures, the wedge pressures, that also help. And that's an invasive towards the end if the patient end up in ICU. So this is 2 or 3 things which can be used to differentiate between acute LVF and pneumonitis from COVID-19.
Okay. Does troponin levels alter the course of treatment?
Of course, I think I have presented very compelling evidence. I think people have to use this in the multi-biomarker panel. Use the troponins for first 2-3 days. Check the troponin during admission. If the patient's status is changing, if the CRP is going up, include your troponin. Sometimes we don't know, because COVID-19, yes, patient have COVID-19, but patients are dying from various complications, from, you know, the DIC, from PE, from clotting, and from myocarditis, and acute STEMI. So patients are dying COVID. And in fact, I will tell you, I want to share you one more case. One patient came to us, we treated him, he became stable, and we discharged him. Unfortunately, this was in early days in the pandemic. His D-dimer were very high. He was discharged without a trauma prophylaxis. Within 24 hours, he bounced back with a massive middle cerebral artery stroke. And he had such a huge stroke. He was ventilated, and 3-4 days down the line, he coned and he died. So, there is a good evidence out there, as Dr. Razi was also mentioning, that, D-dimers are high, discharge patient on thromboprophylaxis. This is a clotting disease. COVID-19 is causing various manifestations. Just treating with antivirals and tolisibab is not going to help. You have to look at and make sure that you close at each and every hole in your treatment panel. You tick everything. All the boxes have to be ticked, and also the importance of supportive care. More often we try to ignore that. Dr. Razi has alluded that the importance of supportive care for these patients.
So one question for Dr. Najib. Are you there, Dr. Najib?
Yes, yes.
Yes. So emergency PCR done for a patient, and later on, the physicians, they came to know that patient has RT-PCR positive, but they did CT scan and they did not find any ground glass appearance. They are asking what to do.
Well, is the patient symptomatic? We don't know, but the patient has had a complication in the form of MI. Maybe they did emergency.
Thrombosis.
Yeah.
And a positive patient with thrombosis.
Yeah. So this is evident that he had some complication with COVID, though he doesn't have a flu-like symptom or acute respiratory infection. PCR is positive. So what is the question in this one?
What to do with this patient? Like, the PCR is positive, patient doesn't have any symptoms, what to do? The fact that
we have to do the same follow-up as the other patients. Like he should be monitored by himself. Like if he develop shortness of breath, or he become tachypneic or desaturating, then he has to follow up with the general practitioner. And if needed, and if he is concerned that how many days it will be positive, so at least 14 days. I think he has to repeat PCR. I mean, after 14 days, if it is negative, then he is free from COVID.
Okay. So the other question is there are so many questions, more than 60 questions are there, and so many questions are repetitive. So I'm working as intensivist. I'm getting my patients in 30 and 40 years as VTAC and cannot be resuscitated. Could be it COVID positive. Shall we do testing after their death? I think Dr. Tawqir may be able to answer this. Dr. Ubaid.
Yes.
They are asking whether patients after they die due to something, should they be tested for COVID?
It's not a routine practice until unless patient has some suspicion that they had contact with some patients. So it can, otherwise it's not a routine practice to test for the positive PCR for the dead patients.
And there is going to be a presentation on the last day regarding COVID and then death, isn't it?
Yeah.
Yes.
By Dr. Abdulaziz Khan, inshallah.
Yeah. One question regarding this pulse oximeter. They asked me, chest pain, can you use pulse oximeter? Pulse oximeter is a test. Chest pain is a symptom. So don't confuse about this issue. So pulse oximeter is a test for left pulse saturation. So the question can be like this: can we use what are the pseudo low levels of the saturation? So suppose the patient has got cold extremities, so then it can cause low readings. Patient has got using this nail paints or mehendi, nail henna, so it can cause low levels. And patient has got low BP shock, then they can have low levels. So this is called pseudo. So this thing should be the question should be like this. Another thing is, suppose patient has got low saturation, please try to check in other hand. We just warm the hand and check it, reconfirm it. Don't be panic. Just saturation 85 with one finger. Again check it with other hand after just keeping warm. So this is like this.
So there is a question, I'll answer this. Can we start aspirin or NOACs as prophylaxis in high-risk individuals with mild COVID symptoms or even in adults above 40 years? So I showed in my presentation that patients who have mild symptoms and who are not inpatient, there is no need to start aspirin or any anticoagulation. Once they are admitted, yes, they will be started according to the risk.
So, what is
question
your
to
suggestion regarding
Dr. Najib.
INR?
Regarding what?
What is your suggestion regarding those patients who are treated as outpatient cases? And there, do we monitor INR? If we are monitoring INR and if they present with INRs, so do you like to start prophylactic or therapeutic dose of
No. I think in my presentation I told that usually the PT, INR and PTT, they are normal. In some cases there is coagulopathy. There can be prolonged PTT, PT, INR, but so, that is not the basis for starting anticoagulation. If patient is manageable as outpatient, if he doesn't need inpatient services, then there is no need to start aspirin or any anticoagulation. But this has been shown in the studies. But if patient is admitted, yes, it is.
Yes, one question to Dr. Najib. There's some data, people also asking many doctors in India, they're using aspirin, they're using the statins for patient COVID. So what is your experience about these issues?
Yeah, I put this question in this group also regarding those who are taking antiplatelets. They have to continue their antiplatelets, and in case if their INRs are high, as Dr. Zubair is saying, that if it is more than 3 times or 4 times, then in that case you will consider to start a low molecular weight heparin, and you have to continue aspirin and clopidogrel.
You mean D dimers, right, Dr. Najib? You mean D dimers are high?
Yeah, D dimers are.
Exactly.
Yeah, you have to continue. What is your suggestion, Dr. Nurullah, regarding?
I totally agree with that. Because these are two different pathways. One is antiplatelets, one is anticoagulant.
Yeah.
We know that this is a clotting disease. I know we have cases with thrombocytopenia as well, but antiplatelets is not going to give you protection with thrombotic events, with the clotting events. Same thing for atrial fibrillation. We always have this debate about whether aspirin or Plavix is sufficient to prevent any AF related TIA or CVA. Is not. There is a data out there where anticoagulants are superior to antiplatelets. So I think this more or less answers the question.
Yeah.
My question is
statin. Statin should be continued, and I think we should not stop statin. There is no such contraindication that statin.
I totally agree. Yes.
My question to Dr. Nurullah. So the start is that patients was not taking this ecosprin and statins before. So some doctors are, because of the COVID, they are starting as a anti-inflammatory and antiplatelets. So what is your impression?
Most of the evidence is anecdotal. There's no trials out there. So I can't personally. I have not done that in our practice.
But there are guidelines from American Society of Hematology, and if patient is outpatient, doesn't need admission, then there is no need to start aspirin or any anticoagulation, like low molecular weight heparin or NOACs. Once patient is admitted, yes.
Yeah, the inpatient.
Broad, yes.
Ambulatory, in the community, there's no evidence behind it. None of the guidelines and none of the societies will actually promote it.
Dr. Taqir is around. Dr. Taqir. Dr. Taqir.
I think it's not there.
Okay. There is a question about CORAD scoring. Probably in subsequent lectures tomorrow or after tomorrow it might come.
We need a lecture on, I agree, HRCT.
And there is another question on what medications to be used at different stages of COVID-19. This also will come in subsequent days, inshallah.
Well, is there any indication related to CORAD staging that we have to start medication? I don't think there is such guidelines that based on CORAD scoring, you will consider to start some treatment, because the treatment is based mostly clinically. I mean, you have to categorize the patient as a mild to moderate who doesn't have hypoxia. I mean, who doesn't have shortness of breath or desaturation. I mean, oxygen level less than 92, or they are not tachypneic. Then they are categorized as mild to moderate, and those categorized as severe or critical when they develop this desaturation and hypoxia. So based on this, the treatment we have to consider, not based on the CORAD, because I have seen a lot of CORAD 4 and 5 also. Their saturations are okay, normal.
So what's your advice for the people in the community, like, walking, with COVID, asymptomatic? What do you do with these sort of people? A lot of questions are cropping up, like, people are treating.
There is a lot of anxiety in our community. I mean, related to COVID, because people should get some good reassurance that 80 to 90% cases are mild to moderate. Most of them they are recovering. Most of them, they are just carrier or asymptomatic also, which have not been evaluated properly. I have seen a lot of cases in Hyderabad. I mean, they contacted me, and they have a lot of comorbid conditions and elderly people. They recovered with mild symptoms. I have seen. I mean, I heard that they recovered, and without any complication. So we have to give a good reassurance to our community that it is just 80%, it is just 10% of cases you can say that are complicated and need hospitalization. And out of that, 5% are going on ventilator or non-invasive ventilation. Otherwise, most of the cases are coming out. What is your opinion, Dr. Junaid, regarding this?
So yesterday I told you, okay, we are not treating the labs, we are treating the patient. Patient is stable, cohort 5 also I don't matter. So patient is stable, moving around, no fever. So I don't matter even cohort 5. So we are treating the patient, not the labs, not the CT. Regarding other thing is, because of COVID, we should not forget other diseases. The COVID picture, what is called this basal and peripheral lesions, can be seen in other conditions. Example, can be seen in eosinophilic pneumonia. So as a physician, always once the patient got peripheral lesions, also look for the eosinophil count and look for the history. Patients will have chronic subacute symptoms like 2-3 months. Could be eosinophilic pneumonia. So don't forget other diseases in the background of COVID. And the patient could have COP, cryptogenic organic pneumonia, as a complication of post-viral disease. So please keep in mind this. So most of the doctors just they see peripheral lesions, they say it's COVID. So could be eosinophilic pneumonia, could be COP. So others don't forget the other disease. Even I was just reading literature. The patient of COVID can have also co-infections with influenza, with typhoid, with malaria. So please don't forget to also look for these diseases. Just only panic of pandemic, of course, should be highest suspicion be there, but don't forget about malaria, typhoid, other influenza infections, other diseases.
Dr. Parvez has joined us from Hyderabad. He wants to share his experience, and how he's managing the cases there in the community at the moment. Dr. Parvez?
Good evening. Assalamu alaikum. Just thank you for allowing me to join. Just wanted to ask a few questions to Dr. Nurullah, Dr. Zubair, and Dr. Najib as well. And I just wanted to add a little bit about CORAD scoring. The CORAD scoring is basically, it will help us determine whether it is COVID or non-COVID cases. It will not say anything about the severity of the disease. So the severity of the disease has to be separately scored, where each right upper lobe, middle lobe, lower lobe, left upper lobe, and middle lobe will be given as a severity scoring of more than 50% or less than 50%, more than 75%, and so on. Depending on the severity of the scoring, that patient can be considered even if it is asymptomatic or mildly symptomatic, that patient will more likely to get symptomatic later in the state, depending on the risk factor, age plus comorbidities. These patients should be closely monitored to see getting respiratory failure, like, closely monitoring the oxygen saturations. That was just one point I wanted to highlight here. And the second, I would like to ask a question to Dr. Noor regarding, we recently started using Favipiravir for patients with mild to moderate disease, and we have encountered multiple patients having same cardiac arrhythmia just like hydrochloroquine, SCQ. And it has become a trend now that almost all patients with mild to moderate disease, or even though are asymptomatic, are started on Favipiravir, even though there is already cardiac toxicity associated with it. And we have other medicines like Azithromycin, and the patients are also taking hydrochloroquine. Do we do we do you suggest to use magnesium supplement in patients who will be started on these drugs who are having potential for cardiac toxicity?
I think it's all anecdotal evidence. There's no hardcore evidence out there regarding the use of magnesium. I've read this regarding this with Favipiravir and magnesium. To perfectly honestly, I don't know. I mean, if it works with your patient, I think you carry on with that. But for me, if someone comes to me with this, I probably won't do it. The only thing is that, treating just magnesium without correcting potassium, as you know, the hypomagnesemia and hypokalemia, they go hand in hand. So both of these electrolytes have to be corrected to, for potentially treating any cardiac arrhythmias. Hypomagnesemia particularly important because of the risk of polymorphic VT and torsades. So again, which goes to the same point, like, all these macrolides in very, very pro-arrhythmic drugs. And like when I was in UK, and every antipsychotic before they used to get initiated, as a junior doctor, even as an SHO medical intern, we used to get a ECG faxed across from a psychiatric unit that we used to report that ECG, that patient heart rate is okay, QT is fine. Then only they used to start the all this medication. So we still have to go by the book. Just because we're not having a data out there doesn't mean that patients are not dying in the community. Patients are dying. How do we know that a COVID-19 patient taking hydroxychloroquine has not died from a VT, VF from a QT prolongation? We don't have the data. Exactly. That's the thing.
Thank you, Dr. Noor. Thank you, Dr. Noor. I have just quick two questions for Dr. Zubair. So number one question regarding the use of NOACs instead of low molecular weight heparin. We have seen a lot of hospitals here, and especially the pulmonologists using NOACs instead of low molecular weight heparin. What do you suggest? Number one. Number second question is, if the patient is already on anticoagulation, already on NOAC, or already on warfarin with a therapeutic INR, do these patients need to be again started on low molecular weight heparin? Thank you.
I didn't get you. What was the first question?
The first question is, instead of the patient who has a high level of D-dimer, and then the patient who are moderate to severely sick with COVID-19, do this patient need to be started on, this patient needs to be started on anticoagulation? So would you suggest NOAC, new anticoagulation, oral anticoagulants in place of low molecular weight heparin?
Well, if a patient has moderate severity or severe severity, then patient needs admission. They need to be on anticoagulation, as I mentioned before. Regarding the DOACs, till now, data is not there, and in some area, some people are utilizing Fondaparinux also, apart from low molecular weight heparin. What was the other question?
The question was regarding the NOAC. It's affordable, it's easy to give, it's oral. So the doctors are prescribing in Hyderabad routine use of NOACs for moderate disease at home.
ASH doesn't, American Society of Hematology does not advise.
Okay.
It still suggests to give low molecular weight heparin, especially for inpatients.
And the second question was, if the patient is already anticoagulated with warfarin or Coumadin or NOACs, and this patient has severe disease admitted to the hospital, do this patient needs to be again started on low molecular weight heparin and the NOACs to be stopped?
Well, it is a tricky question to answer because those patients, if they are on warfarin, it deals with PT and INR. Whereas if they are on DOACs, like dabigatran, it prolongs PTT. Whereas if they are on apixaban or rivaroxaban, it prolongs PT. So right now there is no data regarding this. But if patients are, on therapeutic INR, I think the pragmatic approach would be to continue the same warfarin with therapeutic INR.
Thank you, Dr. Zubair.
Yeah.
I think Dr.
So
Nurullah,
there is one question from one of the participants asking about use of nitric oxide in severe cases in the ICU.
The guidelines clearly says does not encourage use of nitric oxide in severe cases. The routine use of nitric oxide is not recommended as for severe cases. Only it is under trial.
Okay, one question for Dr. Tawfir. Dr. Tawfir, are you around? Okay, Dr. Obaid. There is a 49-year-old diabetic patient tested positive, ground glass appearance on CT, SpO2 98%. What should be done? What should be tested immediately to check any deterioration of the condition?
Yeah, deterioration again symptoms. So patient has got history of fever and cough is persistent cough and dyspnea on exertion. So these are the parameters to judge to decide where to go, what medication to start, not by CT. So patient has was fever is there, and dry cough, persistent dry cough is there, and dyspnea on exertion, then you have to consider.
So one question is there. Even though the D dimers are high and more in favor of COVID, can we thrombolyze?
Thrombolyze what, for PE or STEMI or?
Yeah, it is not mentioned, but broadly we can say yes if it is MI.
You see what
Dr.
I'll give you an example. Like suppose, imagine that we are not in a pandemic. Okay, suppose you're just seeing a patient in emergency as a STEMI. You have to take a decision within 10 minutes after looking at the ECG to thrombolyze. If you're not thrombolyzing the patient within the first 10 minutes, you're doing a disservice to the patient. So just ignore the D dimers and everything. If you think the patient has a STEMI, either you thrombolyze the patient or take the patient to the cath lab. All this academic discussion of D dimers, everything comes secondary because patients will have, because time is muscle in a STEMI. If you need to make sure that the patient live and longevity goes up, you have to do something to restore the flow to that muscle, which is being necrosed. So your outcome will be depending upon how quickly and how promptly you address that issue in front of you. If you wait for the D dimers, it's going to take you another 40 minutes, and by that time, the story finish. So just go ahead and thrombolyze the patient, making sure that this is a true STEMI. It's not a false STEMI like myocarditis.
So one question is there is thrombocytopenia, then PTT gets prolonged. Then if we give anticoagulation, doesn't that lead to bleeding complications? So bleeding in patients of COVID has, it is very rare. Bleeding has not been seen in patients with this. If there is thrombocytopenia, if PTT is prolonged, that means patient is going in DIC. That means patient is becoming critical and he may die because of that. So developing DIC indicates severity. So if there is the situation is like this, if there is thrombocytopenia, if platelet count is 30 or more, give prophylactic dose of low molecular weight heparin. If platelet count is 50 or more, give therapeutic dose of low molecular weight heparin.
So Dr. Nurullah, I think already they are late.
I think let's conclude. I think we had a very interesting topics, and I think because we are in the business end of the webinar, we gone through the initial introduction by Dr. Ubaid. Then we were extremely lucky to have Dr. Razi from America, Houston, who came and touched on very important points of timing of your tolisibab, supportive care, spontaneous pneumothorax. And later on, Dr. Zubair had a very exhaustive talk on the hematological biomarkers and cytokine release storm. And finally, I touched the importance of cardiac biomarkers and how the COVID can present with the various cardiovascular manifestations. I think, Alhamdulillah, we have achieved so far, very important topics. And tomorrow we will be covering the serious end of the COVID-19 pandemic, the guidelines, the intensive care, and so I think we have few more very informatory webinars, and I seriously request all the participants to make an effort to come and attend and benefit from the knowledge. All the speakers, they have made a tremendous effort and sacrifice to come up with these slides and presentations, and just to help with the community out at large in Hyderabad and rest of the India, so that you can help the people out there and use the experience from us to provide good patient care. Thank you very much, everyone.
You can end the meeting now.
Yeah, I think I think Dr. Tawhir yesterday, Dr. Tawhir mentioned that, we should have like 5 minutes towards the end after the meeting finish, that we should just have as like a feedback among panelists, like how things went smoothly, what was a good point, what was the bad points.
Can you send one more link to all of us after ending this meeting? Send a new link.
Do that. Okay, that's fine.